Good afternoon. Thanks for sticking around with us. It's 1 o'clock on Friday the 13th. So my name is Jordan Dow. I'm one of the ultrasound fellows at the George Washington University, and sharing the stage with...
I am Kat Ogle. I am the Ultrasound Fellowship Director at GW. And our other co-presenter is finishing up Sono Games. It's Dr. Craig Bulger. She is at the Ohio State University.
So I have no financial disclosures.
No, I don't have any financial disclosures.
Okay. And we don't intend to discuss any sort of unapproved or investigative use of any commercial products or services. Here's the learning objectives. I don't want to belabor this. You all can read. And in general, we wanted to kind of start from top to bottom. I'll give you a moment to just kind of read some of the objectives.
They can also be found in your program manual.
And then in the spirit of mindfulness, I wanted to say that be sensitive to the fact that there is some triggering content in here and some content around abuse, death, and forms of violence. So once again, thanks for coming to our ultrasound, or our trauma-informed care talk. This is also a bedside ultrasound talk. And so we have the proverbial black background. And this is us from the ultrasound world to SAEM saying hello, bottom right. Kind of like more like this type of hello, top left, like this slider, sort of waving. And if you understand the context for that joke, you understand a little bit of ultrasound. And I can gauge your understanding that I think you know that this top right image is a lung floating in pleural effusion. And I can imagine that most of us have had experiences where we saw this effusion and we said, wow, that's huge, it's enormous. And then we get an x-ray. And that change of perspective, or looking at it from a different lens, kind of changes how we think about this patient's pathology. In the same way, on the bottom left, we've got an image that typically would be bad news prognostically. But there's always been times where once we changed our perspective with other tools like M-mode, we can now see and get a better sense for what's really going on with our patients.
So as we move into this space and begin to talk about trauma-informed care, we wanted to gauge your own experiences with or knowledge about trauma-informed care itself, because that could be an entire year-long curriculum, and we're not going to be able to cover all of that in its entirety, but it's always helpful when you're in a group of folks trying to learn new things to know where people are starting from. Originally, we anticipated this would be a packed room. We're so happy that it's going to be a nice, intimate group. And so rather than using the Padlet, which is the QR code here, I'm just going to ask these questions, and I'm going to encourage interaction because I think that will make it most meaningful. And as people answer the questions, if you want to give them the mic to answer. Mm-hmm. So my first question is, how many of you have heard of trauma-informed care? You can just give us a show of hands. All right. So how do you apply trauma-informed care at the bedside? For those of you who know trauma-informed care. You want to share?
Trying to be sensitive to the patient history and what you might not know about the patient history while you're taking it.
Great. So sort of incorporating their lived experiences into the interaction. Any other thoughts about how you might apply trauma-informed care at the bedside? Okay. What kind of clinical scenarios would be useful to apply trauma-informed care in? When you think about applying trauma-informed care, even if you don't know much about it yet, what kind of clinical scenarios would be important to use trauma-informed care? This is the interactive portion of the day.
I think it's particularly important in one-on-one settings.
Okay, so when you're on a direct one-to-one interaction with your patients, okay? All right.
Can someone define it for me?
We're definitely going to do that. That's
we
the next
will.
step. Yeah. Do you want to give them just a very brief definition of trauma-informed care, Jordan?
Sure. And so for brief definition of trauma-informed care would be that we've got patients who come to us with lived experiences that go beyond what happened that day in that moment. And they're coming to us with an entire history that we're never going to be able to fully dissect and fully understand, but there are ways in which we can stay open, flexible, responsive, and resist re-traumatization of a patient.
And we're going to break it down into different components so it makes more sense, and we'll actually talk about the core 6 principles of trauma-informed care. And what I would add to that is by being thoughtful and mindful of what a patient's prior experiences with their lived experience are in the ER, it informs how we interact with them and how we treat them. In general, right now, how do you engage a patient's support system when you're treating them, just in the ER? What are your practices? Okay, so asking them who they live with, so who are their cohabitants? What else?
Is there anyone you'd like me to talk to? Anyone you want to broaden the discussion to help you understand what's happening?
Absolutely. So incorporating the support people in their life, you know, if there's something that someone else who should know what's going on with them. Any other thoughts about how you incorporate someone's support system? Perhaps with disposition?
Anybody give like somebody, like if you're going to send them home, you make sure somebody has someone there to receive them.
Okay. What actions are you currently taking to empower your patients?
So underscoring receptivity questions from them.
Okay, so underscoring being receptive to their questions and responsive to their questions. It's a great one. How else can you empower your patients in the ER?
Think bedside ultrasound too.
All right, let's go on to the next.
So I think some of us, maybe we think about these trauma-informed care thoughts kind of naturally. Some of us think maybe have not experienced the framework of trauma-informed care, and therefore it's something that we can develop within us. Let's skip past this.
Yeah, I think we'll skip that one.
Yeah.
Actually, no, let's go back to that, because this is, we're not yet in the ultrasound portion. So can you tell me about a time when you might have corrected a learner at the bedside because they said something to a patient that perhaps didn't land as intended? Just by a show of hands, have you ever had to correct or fix a challenge based on what a learner may have said to a patient? Okay. How did that feel?
Well, certainly when the learner has said something that really think is misleading the patient, I'd like to correct it later, but it had to be corrected on the spot.
Mm-hmm.
And that was a very delicate situation, or it always is. So I almost have to do a sort of a, I don't know, a backpedaling that's very awkward.
A little damage control. Anyone else had an
Thank you.
experience where they had to correct information that was delivered to a patient by a learner? Okay, there were 3 hands that went up. I saw 3 hands go up.
Yeah, I've taken like a med student to see a patient and, allowed them to, kind of do history and stuff like that. And I had this one that just kept talking to the patient and kind of thinking out loud. The patient was saying a lot.
Mm-hmm.
A lot of things.
Yeah, so
a
you're...
lot of big scary things and, just finding a tactful way to kind of cut them off and, like you said, awkwardly try and backpedal a little bit with the patient. And, but then simultaneously after that, having a discussion with the learner
Mm-hmm.
and trying to use it as a teaching moment.
Right, right.
Obviously they are going to feel bad and uncomfortable after the interaction too.
Mm-hmm. Mm-hmm. So just for the people who are listening on the recording, the experience was a medical student who is very excitedly interviewing a patient and going through an extensive differential diagnosis of very scary things that may or may not have been relevant to that patient, and then using that as an opportunity to build your relationship with your patient, but then also to teach the student about some things. All right, Jordan.
our words have, and our actions have impact. And I've been on either side of that. I've been the med student, and I've divulged too much information. And then now, as I've progressed, I've been the person who needs to backpedal and try to do some damage control. And all of that is incredibly subjective, incredibly difficult at times. And you mentioned something in the back about how that person the med student might feel bad themselves about what they did say. And we ourselves come to the bedside or to the hospital or to this profession with trauma ourselves. We come with our own experiences and our own difficulties, and then we develop trauma within the profession. We have these experiences that shift and change how we think about the world. And so first and foremost, we want to be mindful of our own trauma and our own experiences. But someone asked for a definition, and I think typically we would define trauma as like ped struck. Someone got hit by a car, stab wound, gunshot wound, but somewhere in my mind, I can still remember that there's a little bit more to trauma than physiologic.
Mm-hmm. Yeah, I think we've covered that there can be emotional trauma, there can be psychological trauma, and there can be an interdigitation between all different forms of trauma.
And so luckily, some of the most research that's been done and the frameworks that have been built out for trauma-informed care have been through the Substance Abuse and Mental Health Services Administration, so SAMHSA. And in 2014, they set out to define trauma. And so they said trauma or individual trauma is the result of an event or series of events or set of circumstances that's experienced by an individual, for us, maybe ourselves or the patient, as physically or emotionally harmful or life-threatening, has lasting adverse effects, and therefore will impact the patient's ability to function mentally, physically, socially, emotionally, and will affect their spiritual well-being.
And Jordan, I think one really important part of that is that it is defined by the person who experienced it. So we may not view a history as traumatic, but to the patient it might be because of something else they've experienced. Just like what we've experienced is weird stuff that everybody else is like, why would somebody screaming be traumatic? You're like, well, you don't see what we see, right? So I think that's just important not to bring your own baggage to the table when you're trying to understand trauma. It's whatever they define it as, not what we define it as.
Experienced by the individual. Yep.
So here is a snapshot of the 6 principles of trauma-informed care. And we're going to dissect each of these individually, but really first want to talk about starting with safety. And this is physical safety for the patient, but it's also psychological safety. So what are we doing to build our relationships at the bedside with our patients? And I mean, for the folks that are in the room, you're in this room because you love ultrasound or you want to incorporate ultrasound into your practice. So that's an incredible tool that you can use to build that relationship at the bedside and to enhance your patient's sense of psychological safety.
Now, we have a lot of experience with safety as sonographers. We tell the patients all the time, this is a much safer imaging modality than the CAT scan. There's no ionizing radiation. And so in that way, we think to ourselves, this is very safe. But from the patient's standpoint, they're also looking inside their body while they're also experiencing a traumatic event, likely in that moment. So definitely, we want to start to think about safety a little bit comprehensively. In addition, the next pillar of trauma-informed care is trustworthiness and transparency. And my brain can think about trustworthiness really well in the hospital. I'm a trustworthy doctor, but a transparent doctor, it starts to get a little bit difficult. There are some situations in which transparency can be not straightforward, and so I think it's important for us to think about these two together and think that you are being transparent in order to build and maintain trust with your patients.
And for those of you who are ultrasound educators, that transparency needs to extend to educational scanning. We do a lot of scanning of normal people or people that are coming in with different complaints simply to teach our residents and our medical students what normal anatomy looks like. So it's important to be transparent with the patient about how that is being integrated into their care. Is it going to be billed for? Is it going to be delivered back to the care team who's taking care of them? Where is this information going? And if you find something abnormal, then what? What's the next step? How do you deal with that? So being very clear and transparent with your patients about that process is really important.
I think the why is really important because a lot of times the more people that come into your room, the more worried you get that something's wrong or something weird is happening. And you're the interesting patient, which no one ever wants to be. And so I think, especially ultrasound teams tend to be fairly large when you're teaching. And so like now 6 people come into your room and you thought you were going home today. And you probably are still going home today. So just being very, because that can trigger a lot of anxiety for people that then manifests later when you're done because you're just the ultrasound team, but now everybody else is left to deal with that.
To deal with it afterwards. The next pillar of trauma-informed care is peer support. And you know, when I first was introduced to trauma-informed care, it was pre-ultrasound fellowship, and I learned it in the context of these peers who were brought into our emergency department. I'm a graduate of Kings County's emergency medicine program, and there was a group of violence interrupters called Kings Against Violence Initiative, or CAVI, if you've ever heard of it. And if you're from New Orleans or worked in Chicago, you may have heard of the Ceasefire program. And so Ceasefire is similar to CAVI in that we take people with shared experiences, maybe even shared traumas, and they're a part of our delivery of service. They aid us and help us as people who maybe don't have, I might not have the same experience as my patient, but I'm going to use this peer support tool as just another one of my trauma-informed care approach.
And how would you incorporate that into ultrasound? That's for you, Dr. Dow.
Personally, I think that I've had many times where I've had family members at the bedside, and I think I was initially trained as anytime you do a procedure or an ultrasound, you're going to ask somebody to leave and make sure they're out of the room. And then me not thinking holistically about peer support, I think my reaction was to always keep the family at the bedside. I think this is the right thing to do. And I think now, as I've really reflected on this, all of these are things for you to kind of reflect on and respond in the moment to the patient. So it really depends on the patient. I think if I'm ultrasounding at the bedside, maybe that family member would be helpful. Maybe they wouldn't. And that's difficult for me to know, and I'm not expecting us as ER doctors to answer that. I am expecting us to think about it, reflect on it, and try to build that trust with the patient so that way we can make a shared decision maybe.
And, no, you go.
I was going to say, I think one big thing is about empowering your patient and not assuming you know what they want or what they need. Like a miscarriage, you're like, oh, you need people here. Well, maybe they don't want anybody in the room. Or maybe they brought their neighbor because that's the only person who had a car, and that's going to be awful. And so I'm big on patient empowerment. Like I do a lot with sexual assault survivors, and I think that that's just something like we are powerful, and maybe you don't feel powerful on a daily basis, but by virtue of your title and your role, like you're already over top of them in some way, shape, or form. And so giving them as many rights and choices as possible in their care, because they can't say, well, they can, but they rarely will say, no, I don't want this, or no, I don't want that. A lot of patients just go with what you tell them to do. And so giving that power back to your patients goes a long way.
And we probably haven't seen much of this in the pandemic, but as our visiting policies are modifying and we're beginning to see people at the bedside again, don't forget that they may have brought their neighbor. And so when you pull their gown up to do their ultrasound, maybe their neighbor, maybe they don't want their neighbor to see their belly. Maybe they don't want their neighbor to see their chest. So confirming who's in the room and asking the patient if they want that person to stay in the room during the ultrasound.
Craig, you kind of like are segueing into this next pillar of trauma-informed care called collaboration and mutuality. And I myself, I think maybe pre-medicine, the trauma that I bring into this space is that my interactions with power typically were that I didn't appreciate the power and the way it was wielded. But now that I'm in a position of power, I recognize, okay, well, for me to just give up the knowledge that I have that's power, and for me to give up the authority that I have that is power, is also kind of not really what is best for patient care in general. So taking that power difference and then not leveling it so that it completely doesn't exist, but bringing your power down to the level of the patient so that way they can understand what it is that you're trying to do, what it is that you're investigating in a mindful way. That's what collaboration is. And so that goes beyond just you and the patient. That goes with the organizational staff, maybe even, and for this talk, for this purpose, the echo technicians themselves or anyone else who's going to be at your patient's bedside.
I think that goes a long way with getting buy-in from your patients. Like, as much as the trustworthy and transparency, I think this is actually probably the most to get, like, we've all had that patient who's like, I'm going home. And you're like, you shouldn't. Like, you're not going to make it back. But there's been a trauma associated with the hospital. Even if it's just like My one that comes to mind immediately is I had this like 85-year-old farmer who was like, and I sat there and I was like, my heart, your heart. And I did that for like 20 minutes, like, until he was like, oh, I was, maybe he was just sick of me. But I was like, he's like, I have to go plow the fields. I was like, your heart can't plow a field. Your heart can't walk down your driveway. Do you want your wife to find you at the mailbox? And he said, absolutely not, but I don't want her to be by herself. And every time I come in here, she's by herself. But like, he just didn't see it in that, because to him, we were robbing him of time with his wife by keeping him in the hospital. And so it was letting him have that choice. I wasn't gonna make him stay. I just wanted him to know, because he was not grasping it. He was like, I'm gonna go bale hay and do all these things. And I was like, you are not. You will not make it through that.
Yeah, and I would add with the collaboration piece, sometimes our patients come in with complications from non-adherence to whatever their medical regimen is. And so the thing that comes to mind for me is someone who's profoundly hypertensive and they're not taking their blood pressure meds. You can take a bedside echo and you can show someone the way their heart is functioning, and you can show them LVH on the screen, and you can say, I know you feel good, but this is what it's doing to your heart. This is what a normal heart looks like.
Yeah.
This is what your heart looks like. I'm going to start using that. My heart, your heart, my heart, your
Ideally, we have normal hearts.
Yeah.
heart. Ideally,
No
right.
surprises.
That's right.
Exactly, and I think I would echo all of that. And even empowerment itself is one of the pillars of trauma-informed care, and this really involves, like, the patients know they have a voice and a choice. Do they still feel that way when they get there to the hospital? And I think it's really important for us. I think the overall goal, especially with bedside ultrasound, is to empower the patient to understand that you can heal, and our goal is to heal. So I think long run is empowering patients to see that. The last pillar of trauma-informed care is humility and responsiveness, and we kind of put up that goes for any of the differences that we have between our patients, whether that be age, sexual orientation, ethnicity, gender, geography, that our differences can be chasms, or with humility and responsiveness, our differences can be bridges.
So when we think about these 6 pillars of trauma-informed care, those are really talking about what we can do actionably at the bedside, what we can do with our patient care decisions. But it goes beyond that when we start thinking about what can we do as organizations to create spaces and cultures that provide trauma-informed care on a holistic level and on an organizational level. So the first step in this 4R framework is the realization that trauma is ubiquitous. Individuals have trauma, families have trauma, communities have trauma. And so it's as much as it takes a little bit of extra time to talk about where someone is coming from and what they're experiencing, having a little bit of background about where someone lives, what kind of environment they live in, what their safety situation is, what their food situation is, do they have housing insecurity, all of those things can contribute to the way they interact with your staff. And being mindful of those things is really, really important. The next thing is starting to think about what are the signs of trauma? What are the signs of non-physical trauma? We know physical trauma back and forth. We know ATLS back and forth. That's not difficult to see. What we need to start thinking about is how can we uncover the underpinnings of psychological and emotional trauma as a result of a person's lived experiences, and how does that inform the way they behave in the emergency department? So rather than having your staff say, why is this patient such a jerk? Why is this patient screaming? Why is this patient so difficult? Why is this patient leaving AMA? What experiences has that person had that informs the way they are behaving? What is their story? What is the backstory? What's going on behind the scenes? And if you create a culture and an institution that explores these topics, then everybody starts asking those questions, and we all start taking better care of our patients. The next step is making sure that you're resisting future harm. And so, this is probably prevalent in the trauma bay. You get so many people around a patient in a trauma, and that patient is freaking out because there are 15 people around them. Sometimes the person who's leading that trauma resuscitation has to stop and reset and check in with the patient to make sure that the patient is getting what they need. Because they've just been hit by a car. And now you're tying them down, you're holding them down, you're doing a rectal exam, and they completely feel violated, and they just got hit by a car. So you're making it worse. Or are you putting a chest tube in without giving any analgesia? just because you think you need to do it faster, that is going to further traumatize the patient. Similarly, we need to be thinking about how we can use ultrasound to avoid re-traumatization. And then the last piece of this is making sure that you have global policies and procedures in place so that everybody knows how to make this work.
I think scripting can be really helpful here. Like one of the phrases help me understand. Like, you are now empowered. Help me understand. How can we make this different? And I've gotten some very insightful conversations from that where people are like, they're just a jerk, they're cantankerous, they just don't want to do anything. And like one of my patients was like, I don't trust pills that I don't buy myself because my friends were in the syphilis project. I'm like, oh, that's very reasonable. What would you like to do? They didn't want to not get care. They just had certain fears that they couldn't overcome. And everybody was ready to be like, walk out the door, buddy. And this was like an 80-year-old hectic man that should not be walking out the door and was wanting to get care and wanting to get answers, just didn't want meds. That was it. I was like, that's fine. So I think help me understand goes a long way, and it puts you in a position where you're receptive to them and you're not telling them, because I think we often come in with, this is your high blood pressure and you're gonna die from it, right? Like we come in with our AMA speech instead of help me understand.
And I want to be clear that this is, these, this is SAMHSA's development of, and for those who are new to this, these are the 6 pillars of trauma-informed care, and I think they're what I want us to take as individuals, especially at the bedside ultrasound. But these 4 R's are really organizational 4 R's. They're really about making organizational change. So everything we're talking about in this slide is really from a higher level. But let's take it back down to the bedside. Let's take it back down to the individual. So I'll give one brief story that I experienced that kind of reminds me how important this is. So at a busy 22-bed ER in Washington, D.C., I receive a patient, 47 years old, via EMS, says she has left flank pain. And their initial vitals, history, the context surrounding them coming here to the ED was all divulged in the triage area. 2 EMS personnel, myself, the triage nurse, and then the 3 other stretchers with EMS personnel and other patients behind them. So all of this was happening around the patient, and for me, running through my head are all the other high acuity patients that I have to tend to. And so I made the decision to do an abdominal exam in the triage area. And so really, flank, abdomen, I got no tenderness. I tried, I really only got blank stares from her when I would say, any pain here? Any pain here? Kind of blank stares. So I decided I'd need to do a better exam and do this in the room, the actual room, once they got there. So I maybe went in the chart, tried to read about her, didn't find anything in the chart, circled back around, and when I got to the room, she was on the floor. And the blanket had been laid out perfectly on the floor, and she was laying on it in the fetal position. And I asked what happened, and she said she fell. And I helped him up to the bed and finished the exam and still couldn't find any appreciable tenderness, no grunts, no grimaces. But she did mutter for a moment, morphine. I need morphine. So I stop and I pause and I back up a little bit. I just want to share what was going through my mind. I was thinking, Jordan, you're not stupid. You're not stupid. You fell on a blanket that's nicely laid out on the ground and telling me only you need morphine? I was like, I've been naive before. I was a medical student, I was a resident, but no, I'm an attending now. We're gonna stop this here. I've seen this drama before, smells of malingering, and how many more times am I gonna be taken advantage of, before the patient walks out of the ER and calls me Dr. D for Dilaudid? I really started thinking about all these pathways to opioid addiction, and in my mind, the only thing I could think of, and the only way in which I thought about her life prior to me meeting her was that she must be addicted to opioids. And that's my honest truth. That was what was going through my head. But I breathe through these thoughts, and I help her to the bed and finish the exam, and she still whispers, morphine, I need morphine. And she's, once again, only findings I have are no appreciable tenderness. So I bring the ultrasound to the bedside, because that's my way of I guess in my mind, it's a tiebreaker. I didn't even share this with her, but in my mind, I'm thinking, okay, if there's really something going on, then I'll see, if you're in that much pain and all you can mutter is morphine, I'll see something. So I'll give it a shot and I'll put the probe on her body, and I did. And for those of you who know ultrasound, you can see large amount of free fluid, posterior acoustic enhancement. So that's not even the structure. That's fluid, a lot of fluid in her belly, right there at the left upper quadrant, kind of where she had told them initially she had pain. And in that moment, I'm also doing a better exam. I've got the probe on her body, and I can see bruising and tenderness in that area, where I didn't get any tenderness, or I didn't get any objective.
Are you worried about her now?
I am. Whew, I'm not only am I worried, but as I'm scanning down the paragolic gutter, she now is able to say, "Hey, I think it's time for me to leave now. Can I just sign that paper?" Hello?
Dr. Dow,
Yes.
the patient's mother is on the phone.
So let me stop there. Question for the audience. What sort of trauma did the patient have prior to coming to the ER and meeting me? Or Dr. Ogle, do you know what type of trauma she had before?
She fell on the floor on the blanket.
Oh, okay. I guess that's all we know, is that she fell onto the blanket. And really, that's a trick question. We don't know. We don't know what sort of trauma she's coming into this with. We don't have an organizational response to, or maybe not, in that moment, there was no organizational response to her trauma, and I didn't really do a whole lot to get any more information. And luckily, had I not, I don't think I used the peer support part of the trauma-informed care principles. I don't think I used the collaboration at all. I'm examining her in the triage area, and information's being divulged with other patients there. But I think I did try my best to use some humility. And had I not used just a little bit of humility, I might have discharged that patient, and we would have had a really bad outcome. And so, in the end, with that said, we have a lot to juggle as ER doctors, and especially in trauma situations. And so I'm not asking us, and I tell this story because I'm not asking us to be using all 6 principles and developing all 4 R's into your organization. I at least ask that we try to start thinking about this and at least try to use one of these tools, reflect on this when we're at the bedside, especially for patient care. So now some more non-rhetorical questions. What else could I have done to incorporate trauma-informed care, especially in this specific case with my 47-year-old patient?
Now that you have a little bit of an idea of what trauma-informed care is, how else could we have used it in this case?
Determine what setting in which she felt most comfortable doing the exam.
Absolutely. So, ma'am, do you mind if I just take a quick look at your abdomen while you're here? I know we're in the hallway and there are some people around, but do you mind if I take a look? And that would give her some autonomy. Anything else?
Okay, and ask them what she's concerned about, or what the patient thinks is wrong with them.
Mm-hmm.
Like I've gotten a lot of interesting and helpful answers when I ask the patients what they think is going on.
Yeah, what do you think is going on? Help me understand. Help me understand. Any other thoughts?
What parts of her story were missing? What other questions would you have wanted to ask at the bedside?
And I think some of you brought it up, like just calling or asking, like, is there anyone you want me to call? Is there anybody who do you live with? It was a great comment too, because, and then, the combination of like, do you want me to call them? Let them know that you're here.
Mm-hmm.
How about, were there any stereotypes that were at play?
Yes.
She didn't ask for a lot.
She sure did ask me for morphine, and I think, there's a lot of discussion around pain and people's pain, our perception of other people's pain. And for me, in this situation, I genuinely was reflecting on the discussion around people not believing in Black women's pain. And for me to think that I'd be above that or not have my own stereotypes or my own biases, once again, could have led to a patient getting discharged and a really bad outcome.
So, Jordan, I was just going to say, in the interest of time, we probably should move forward to the QR codes and
Yep.
get ready to go into the small groups.
And so, yeah, there's context, there's our own trauma, there's the patient's trauma, and then there's our own ability as an institution to respond to all that. So let's try to take all of these thoughts. We can maybe split the room up into
Three.
Three?
Three.
Okay. Split the room up into three. There's like a corner here, back corner, and then this corner. And then one person download the QR code on the left, one person download the QR code on the right, and then we can go through a couple breakout session cases.
So we're going to take 10 minutes to give you some cases to think about, and then we'll come back and report out.
So each group downloads both codes?